Good afternoon, everybody. We're going to start the session on cancer genetics. So I know you have a lot of very interesting activities going on with the coffee break and the posters and everything. But we have to start because we have a hard stop at 5:20. So before I introduce the speakers, I want to remind everybody about Pigeonhole. I know if you have been around since morning, you have heard it 20 times, but another time. So Pigeonhole, you can scan this barcode, and pigeonhole.at, and the Q&A can be submitted through the portal with the password being PIC24. And yeah, so please submit your Q&A through that. So it's my honor and privilege to introduce the first speaker today, Professor Joanne Ngeow. She is an associate professor at the Lee Kong Chung School of Medicine, if I pronounced it correctly, I hope. And she's also a senior consultant in Division of Medical Oncology at the National Cancer Center, Singapore, and heads the NCCS Cancer Genetics Service. Professor Ngeow has a very distinguished career. I'm not going to read all of that, but I'm very proud to introduce her today to talk about cancer predisposition in Singapore, insights from SG10K and beyond. Please.
So firstly, thank you. It's the afternoon session, so I hope everyone's still doing quite okay. It's really lovely to see all the visitors in Singapore, and I really hope that you guys get a chance to actually visit Singapore as well, other than stay in the conference. It's my pleasure to be part of the PRECISE program, to be leading one of the clinical implementation pilots, and to share with you some of the insights from both the scientific side, which is insights from the SG10K study, but also some of the clinical aspects of what we're doing with that data. So in terms of the talk outline, I'm going to go quite quickly through the peak of our local data, some findings from the first 10,000 Singaporeans that had whole genome sequencing done, what that's taught us about hereditary cancer syndromes in Singapore. Throughout that, I'm going to share with you some of the barriers to implementation of genomics in Asia. I think a lot of folks have already spoken about the lack of population data and how that's impacted variant curation, data access, and etc. And the same is true in Singapore. That as a result of that, there's clearly implications on clinical care, and just give you some insights of how we've overcome some of those barriers in the Singapore context. I like to start a lot of my talks with this slide, which shows a snapshot across Asia, because I know many of us come from different parts of Asia. Asia's a continent, it's not a country. And as such, we have very different epidemiologies. We're very distinct healthcare systems. I highlight Singapore there. Singapore, the commonest cancer in men is colorectal cancer. The commonest cancer in women is breast cancer. It is for that reason why our understanding of hereditary breast and ovarian cancer syndrome, Lynch syndrome, is quite critical, because at the moment now, our public health screening, that's actually at the moment mandated through Healthier SG that you heard about from Patrick earlier, is actually an age-based screening program. And it's, as such, it's not well served to meet the needs of HBOC and Lynch syndrome patients where there are a cancer predisposition syndrome. And so I think the priorities in Singapore might be different than, for example, priorities in Vietnam, where, for example, liver cancer remains a key issue, and where, therefore, the public health priorities might differ as a result of that as well. You've already seen Patrick show this slide. This is the other reality. One reality is that we're in different health systems. The other reality is that the actually baseline breast screening rate in Singapore is actually very dismal. We've never gone above 40%. And this got to do with many factors, but one of which is helping people understand that it's important for them. I took out a slide that I always used to have, which is that the commonest reason why Singaporeans don't go for screening, and this has been borne through other studies, is that they'll say they have no time, they're too busy doing other things, or they don't find that they need to because they're feeling okay. And so I think this is where genomics can come and help and educate that aspect. So this is a program I've run for 10 years now at the National Cancer Center, and this is pretty much a similar program that's also running at the National Cancer Institute of Singapore and also at the Tan Tock Seng Hospital. So these are the 3 healthcare clusters, and all 3 healthcare clusters have access to genetic testing, and it primarily runs around a genetic service, a biobank, research that's ongoing, and then collaboration strategically with international partners. This is my program at NCCS, but I want to just highlight that a similar program exists in the other 2 hospital systems as well. And through the precise effort, we've been able to align. In fact, we just had a session where, on Monday where we talked about sharing best practices and how we align across the whole health system. That has been very useful. So when I speak to policymakers and clinicians, the 3 commonest questions I get asked for the longest time is, how common is this in Asia? We've never seen it being reported. Is it really a real problem? Do patients want this, and can we afford this? So over the last 10 years, I've taken turns to addressing these questions because it just comes up so often. And so I'm going to share with you the how common is this in Singapore story, which came out of the SG10K data. So this is published in Nature Communications, and Patrick gave a highlight of it. But just to let you know that from this study, which is co-authored by myself, Soumya Jamor, and Lim Weng Kong, 4% of the Singapore population harbor a clinically actionable pathogenic variant or a likely pathogenic variant. And that's, it's 4% across the board. When you look at cancer, cardiovascular disease, and lipid disorders, you will see that for cancer and cardiovascular, there's no ancestry differences between them broadly, but of course in the individual genes, there are some ethnic differences. For lipid disorder, you will see that in the bottom right here, the lipid disorder, the red bar, the Chinese are much more likely to have familial hypercholesterolemia compared to the Malays and the Indians. If you look at specifically hereditary breast ovarian cancer syndrome caused by BRCA1 and BRCA2 or PALB2, you will see that the prevalence of this is 1 in 150 Singaporeans, which is at the time when this data came out, much higher than I expected. In literature, people use to cite 1 in 300, 1 in 500, it's 1 in 150. You also see that it's slightly more common in the Malay population. This is because there's a recurrent founder mutation that's seen in BRCA1 and BRCA2 as well in the Malay population. In Lynch syndrome, is the reverse. In the UK, it's cited to be about 1 in 250, but we saw it in 1 in 500. Twice less common, but more common in Chinese compared to the Indians and the Malays. And I always say that this is an important lesson about how population genomics actually helps us. We've been running support groups for Lynch syndrome for several years. We only saw Chinese patients in the support group, and I used to sort of tell my team, you're not doing a good enough job reaching out to the Malays and Indians. What are we doing wrong here? And it just turns out that Lynch syndrome, at least in Singapore, is more common in the Chinese. I'm a little bit nervous about saying it's not common in the Indians and Malays because we have very small numbers still in this SG10K data. We're going to await the SG50K data to be sure about that. This is a slide I actually show our policymakers. It says 1 in 150 Singaporeans are at risk of HBOC. But what it also means is that our current breast screening guidelines is wrong in 1 in 150 Singaporeans. And I think nobody wants to be wrong about anything, right? So we want to be more right, and what can we do about that? Through this effort, we also know the other genes, how prevalent the pathogenic variants are in the healthy Singapore population. On the right column is for autosomal dominant. On the left column is autosomal recessive conditions. The autosomal recessive conditions are actually important for us to know the carrier frequency, because by knowing the carrier frequency, we can do things like understand how likely we're going to see some of these underdiagnosed conditions that we may not think of that's in our midst. SBDS is Schwartzman-Diamond syndrome, where patients actually have a risk of inherited bone marrow failure syndromes, and based on the high carriage of pathogenic variants in this particular gene, we expect at least 1 live birth of SBDS in Singapore, and we're certainly underdiagnosing this in our current clinics at the moment. We're not routinely screening our early onset inherited bone marrow failure syndrome patients with any form of genetics, and we are working towards doing that in the near future. Again, by looking at the data, we're able to then look to see whether there are any ancestry differences. And again, like I said, this is the first 10,000. We already shared with you that there are some differences in BRCA1, in Lynch, within cancer. I would say that RET51C, it's very clear that there's a Chinese founder mutation in Singapore. Almost all our cases due to RET51C is due to that. But for the rest of the genes, it's a long tail. And in that tail, I think we'll await the 50K, 100K data before we update whether there's any ancestry differences. So that's the healthy cohort. So if I turn my attention now to the local cancer cohort data that's seen in the cancer genetics clinics, this is data from about 3,500 patients, 3,500 patients that's come through the clinic for genetic testing. What we do see is a whole spew. Most of the genes there are familiar to people who work in cancer genetics. So for example, for breast cancer, the most common is BRCA1, BRCA2. For ovarian, same thing. For Lynch, the MLH1, etc. This is similar. Although the genes involved are similar, I would say that the variants involved, there are some differences. And as mentioned already, in some of these genes, there are founder mutations there. But having this data has been useful in helping, for example, labs want to deciding how to whether is there a need for a different panel for Asia, for example. This doesn't suggest that there is a need for that. This is also interesting. If you look at the actual variants that have been identified in the cancer cohort, which is in blue, versus the ones that's been seen in the SG10K healthy population, you will see that the overall overlap is very small, as expected, because we only have 10,000 in the general population. This does suggest that we do need to get much bigger cohorts, 100,000. It also suggests that getting to 100,000 may not be enough. We do need to actually sequence the disease cohorts as well. And so I'm quite happy to hear that in the next phase of the National Precision Medicine Program, we are likely going to go towards that. This is just to share that within even breast cancer, some genes are much more penetrant, and where there's family history is useful, whereas for some of the others, being less penetrant, family history alone is not going to get us there. And therefore, there's a reason that makes a case for potentially considering more universal testing, whether you do it at the population or you do it at the cancer diagnosis. This is also another interesting slide from the cancer cohort. It shows the actual ages where patients with breast cancer due to, for example, BRCA1, BRCA2, or colorectal cancer due to MLH1, etc., are seen in our clinic. And what you will see in the dotted line is the median age, and what you will see in the solid orange line is the age of screening in Singapore. So if we started at 50, we're going to miss quite a lot of breast cancer. If we started at 50, we're going to miss a lot of colorectal cancer. And at this current time and point, we still need to address all those in Singapore. The SG10K data, as Patrick has mentioned, is actually available on this portal, and people can go in and query variants wherever you are. So the third problem that I'm going to quickly go through is the challenges that we see in the US. I think this audience, we do not need to repeat this, that we understand that Asians do face a higher VUS rates. Multiple studies by ourselves and others have shown that these variants can be reclassified and can alter clinical management. Our own data suggests that any time point today, if someone goes for clinical cancer genetic testing with the usual panels, 50% of them will get a VUS result, and over a 6 years of follow-up, that VUS result, by and large, just remains unresolved. This is a more interesting paper that we've just haven't published it, we've put it in bioRxiv. This is looking at we have a lot of variant effect predictors these days. Some of them rely on population data, some of them are population-free. On the left is the population-free, on the right is the population-based variant effect predictors, and using the NOMAD data sets, looking at the South Asians, East Asians, and the South Indian population, as well as using the Mexican prospective cohort study, what we are able to show in the shaded area, which are the thresholds for predicting pathogenicity, that using the population-free data, you see less variability over on the right side when you use the population base. This is somewhat intuitive, but it's also helpful to actually demonstrate and show that if you are coming from a population where it's underrepresented in the databases, and you use a population-based variant effect predictors, you are going to see that kind of differences across on the right side. Okay, speeding up other problems. These are problem statements that when I speak to policymakers, they ask me. So I'm just sort of saying these are what we've done, the research behind, these are some of the answers. So the other question we are asked is, what is the cumulative risk of cancer for known hereditary cancer syndromes in the Asian context? And I know Yuki, my friend and colleague, is presenting after me. And this is, so I will go through very quickly, but this is collaborative work that we've done together. Together with Malaysia, we now have the largest cohort of known carriers with BRCA1 and BRCA2, and for the first time, we're able to put up the cumulative lifetime risk curves for breast cancer and ovarian cancer, and not surprisingly, it is high compared to the general population. But what is quite interesting, and I think Yuki will go into it a little bit more, is that the Singapore cumulative lifetime risk is similar to the Asians that are in the UK and the US than it is the Malaysians compared to that. And so there is, in addition to the genetics, lifestyles, environmental, potentially other interacting factors here as well. So I think this is really interesting. This is the first snapshot we have working together about this. We will need to sort of obviously expand and do more work to understand these differences. The other question that people ask is, does knowing your genetic risks actually change behavior? So very quickly, this is just to share with you. Earlier I shared with you that general population screening is very poor, it's under 40%. But in patients who know that they're BRCA1 or BRCA2, in a captive audience like in Singapore, where we actually have very good records, 84% of them actually go for their mammography screening. And we do this methodology not by just counting the one time they go, we follow them up longitudinally, and if they follow everything, that's a 1. And then anything in between is a ratio of the 1, and anything from 0.5 to 1 equals they are adherent to risk management guidelines. And what we show here is that knowing your genetic risk, and these are largely monogenic, highly penetrant conditions, the population is actually able to to follow the guidelines, able to access the guidelines, and follow it. It's also quite sane in the sense that if you look at colonoscopies, Lynch syndrome and FAP, these are two conditions that have put people at very high risk of colorectal cancer. You will see that the adherence to risk management is high, 70%, 80%. We were quite pleased when we saw this. And quite appropriately, for the moderate risk genes, which like ATM and the rest, where we don't really expect people to really be adhering to it very strictly, it's about 50% that they're going for their colonoscopies as they should. Okay, the other question we have is, this seems very labor intensive. You know, you find out someone has genetics, and then you have to do all this surveillance and all that. And a lot of times we're asked, can we scale this at the population level? Yes, there are two reasons why we can scale this. The first reason is those who do not need it won't be having the unnecessary investigations. So that's one way, and that's the whole idea about risk stratification. The other, but that's theoretical, right? So theoretically that should work. But in NHS, my colleague and friend, Kevin Mollahan, has already done that with Lynch syndrome. He has made a very big program of triaging who needs a colonoscopy goes first, and actually it doesn't add additional burden. It's calculated to increase the actual colonoscopy by, per colonoscopist, 1 per week extra to deliver this care. So I think this idea that, oh, it's too hard to scale, you know, it's too cumbersome, I'm not sure, I don't think the data supports that. I think there are pathways towards being able to scale. Then the problem is, are people actually accessing testing? This is a EMR. We went through the EMR, not me, Dr. Chiang Tianpang in the audience, went through the EMR data, 2 million patients seen at the SingHealth cluster. In patients who met the criteria for HbA1c and Lynch, how many of them actually had access to genetic testing? What we found was that close to 75% of patients who met testing criteria for HbA1c and 85% of those who met criteria for Lynch syndrome testing did not actually go through with it. So this is a big gap that we do need to try and address. It's fairly low-hanging fruit, and we should be able to do that. Problem 6, do patients want to know their genetic risk? I will say that these folks here, these are our support group patients, they do, and they happily advocate on our behalf. But we did a study to try and sort of understand what goes into that decision making. So there is a methodology called informed choice, and by O'Connor and O'Brien. Just very quickly, because I have 2 minutes left, I will share with you that it takes into account a few different attributes: the knowledge that the patients have, their attitude towards that test, and then whether they go ahead with it. So if they had a good knowledge, a good attitude, meaning they want to have the test and they take it, that's considered informed. If they had good knowledge, they did not want to do the test, and the action followed with the attitude, that's also an informed choice. So what we can show you is that in Singapore, the main distinguished factor between whether someone has testing or not testing is whether there is financial assistance. So that's the biggest one there. Financial assistance drives a lot of the decision making. The other thing to sort of quickly highlight is that among the people who don't test, there's a higher degree of so-called uninformed choice or non-valid consent, as I was educated by Julian, that's the better term for this. And this is largely driven by this fact. They have adequate knowledge, meaning they know a lot about the condition, they want to have the test, but they end up not being tested. Half of the people are in this category. Why? That suggests to me that there are external and systemic barriers. I've already mentioned cost is the big one. In the Asian context, insurance is the other. So I'm actually going to be on time because this is my last problem. The last problem is how can we improve genomic literacy in Asia? This is a workshop that Heidi and Sharon took part in just yesterday. We increased genomic literacy simply by honestly teaching one at a time, at scale if we can, but if not, one at a time. And there are 2 fellowship programs that we run, and I was very pleased to see, one of my fellows teaching another one of my fellows yesterday about how to do variant curation. These are 2 fellowships that people from the region can apply for. One's a clinical fellowship on the right, can come and speak to me. One's a postdoctoral research fellowship on the left. And this leads me in the last 2 slides to just want to share that no one epitomizes this better than my former mentor, who sadly passed away a week today. I actually received very, very good training from Professor Karis Ng. She was the director of the Genomic Medicine Institute at the Cleveland Clinic. She really epitomizes the one at a time, and from the one at a time, we've all become many at a globe. So I think a lot of what I've been able to do, I do credit to Karis. And also just to say that Insight, which is a meeting that looks at hereditary cancers in the GI tract, will be coming to Singapore. So please do come back to Singapore for that. So the key takeaways are germline cancer predisposition, monogenic, more common than is appreciated in Asia. It is a pillar of national precision medicine initiatives globally. It's one of the strong pillars. Gene-directed risk management allows for early detection and importantly helps us to tailor the resources accordingly. The ancestry-specific differences exist. The overlap between clinical cohort and general population at the 10,000 level is very limited. We should focus on disease cohorts if we can. We do need to more deeply understand the external and systemic barriers, especially financial in Asia, because capacity building is a problem everyone has. I have some ideas, but I don't have all the ideas. We do need to do that better together. We do need to make genetic testing hard-coded in this part of the world. It's not hard-coded yet the way it is in the UK and the US. It's not as routine as part of clinical practice, and the eligibility for reimbursement is pretty key. And then with that, SG 100K will soon be available. And these are my acknowledgements. Thank you.
Thank you very much, Professor Ngeow. It was a remarkable talk. The next speaker today does not need much introduction, but I'm here for that, so I have to do something. Dr. Philip Awadalla is a National Scientific Director of CanPath, which stands for Canadian Partnership Tomorrow's Health, and Director of Computational Biology and Executive Scientific Director of Ontario Health Study at the Ontario Institute for Cancer Research, and Professor of Population and Medical Genomics at the University of Toronto. He is going to talk about something that includes everything that I'm interested in learning about, integrating cohorts and multi-omics to capture the earliest determinants of cancer and aging. So please welcome Dr. Awadalla to the stage.
Okay, thank you very much. So I'm going to be talking about three things largely today, but largely everything is going to be focused on what I believe is the great strength or value in terms of population cohorts, largely in the thinking about that, that value in the context of cancer prevention and early detection. So I'll be presenting both the population cohort that we have in Canada called CanPath, and how we're using that cohort to understand the biology of early cancer and how we can use that information to develop new technologies for early detection. So I tend to start with this slide, largely because many of the conditions or rates or prevalence of incidence of cancers or chronic diseases tend to be fairly similar. These are the numbers in Canada, and we see these numbers in much of the developed world. But Terry Manolio wrote this lovely article some time ago now, it's actually about over 15 years ago, where she makes the case that population cohorts are population laboratories, and that those population laboratories, when built properly and at scale, can be used to understand many important questions with regard to how health develops, or sorry, how diseases develop, and also potentially the flip side as to who remains healthy as we age as well. So today I'm going to be focusing primarily on how can we understand cancer and what does cancer look like at its earliest stages, and can we use these population studies to develop technology where we can detect those cancers earlier. Now, one of the reasons we want to detect cancers earlier is because our interventions and treatments for cancer are most effective when captured earlier. And so that's all I'm showing here on the histogram on the far right, is that the 5-year survival rates for cancers, many cancers, are highest when those cancers are captured earlier. And so many populations, or many jurisdictions, if you like, have many tools that are out there for screening in the population many different cancers. So, as I mentioned before, Canada has its population cohort. It's called CanPath. It stands for the Canadian Partnership for Tomorrow's Health. It is Canada's largest population cohort. It's captured information from 1 in about every 100 Canadians. Actually, it used to be 1 in every 100, but Canada's actually grown in size. We're now over 40 million people. And in fact, for those who don't know, this is a map of Canada. We've recruited now up to around 370,000 participants. And you got a breakdown of the numbers of how they were recruited in those 10 different provinces. Unfortunately, Canada has 10 different payer systems, and that's impacted how we operationally have to do things. So every province, in fact, has an operational site to support our recruitment. We've been around now for about 15 years, and so we're already in that phase of activities where we're recontacting our participants. We're getting recontact biologics from our participants. And again, one of the big strengths of the CanPath activity is also our ability to link to administrative health data as well as follow our participants to understand what's happened to them since we've seen them. Captured many important variables as associated with health and disease. Over 3,600 is on our CanPath portal. And I also just wanted to highlight, because we are at a IHCC conference, that it's one of the earliest members of the IHCC cohorts. And actually at the University of Toronto, at the Ontario Institute for Cancer Research, with my colleagues Thomas Keane, who was here on stage earlier, and Melanie Courteau, we host the IHCC Atlas at the OICR. And lastly, one of the things that we're very proud of is that from many of these participants, we've collected biologics. From these participants, we've been able to do genomics, we've done genotyping, transcriptomics. You're going to see some work a little bit later on single cells, not much work that I'm going to be presenting on the single cell front. We've captured at 6-digit postal code resolution, so generally we know where all of our participants live, so we know about the kinds of things that they're exposed to through their lifetime. And that's been data that we've been using to support a number of studies that have been looking at, say, climate and environmental change as it relates to health. And there was an article with our colleague Charlie Swanton last year, which used much of the Quebec data that we had in identifying that air pollution impacts, say, cytokines, inflammation, particularly around non-smoking lung, and is an important initiator with respect to cancers. All right, that's just an overview of CanPath in general. And as I mentioned before, I think these cohorts are extremely valuable because they allow us to think both forward in time and retrospectively. We can capture information about our participants They come into our cohort, some of them healthy, and then they develop a disease. And our ability to recontact these participants, and again, link to administrative health data, allows us to say, identify individuals who may have given us a blood sample without a condition or without a diagnosed condition like a cancer. And then we can look in those biologics, for example, and see if there's a signature of that cancer and see how far back we might be able to see that signature of those diseases, especially cancers. So the work I'm going to be talking about largely today is work being done by my student Nicholas Cheng, who's writing up his PhD as we speak, and so some of this is going to be appearing in the literature fairly soon. We've been developing and using the population cohort. I'm just going to be talking about material that comes from Ontario, which is a province in Canada, so you're going to be focusing on one particular province. And we've been developing these liquid biopsy approaches using material collected from the OHS, the Ontario Health Study participants from the CanPath activity. We've been focusing on methylation signals because we like those signals because they tell us not only about whether there might be a cancer present in that individual, but they also give us some information about tissue specificity as well. So we've been training tools and models with materials, say, from TCGA, which gives us those signatures about where those methylation signatures might be coming from in terms of tissue specificity. This tells us that our tools can pretty vary from TCGA data anyway, can discriminate different tissue types. And we've been using those signatures and that information to try to see if we see a signature of those cancers in plasma samples captured from Ontario Health Study participants before they were diagnosed with the cancer. So that's a map of Ontario. That's just a breakdown of our recruitment in the province. And this was our first pull of biologics and samples from the Ontario Health Study. You're going to see data from the second pull in a moment. So from the first pull, what we did was we went to the Ontario Cancer Registry. We asked who's developed a cancer in the Ontario Health Study population and came into the cohort healthy. So we call those our incident cases. And so these are just some numbers for breast cancer, pancreatic cancer, and prostate cancer. As you can see, we have fewer pancreatic cancer cases because the incidence rates for pancreatic cancers are not as high as that for breast and prostate. So generally, the x-axis is normalized at 0. That's when participants gave us a blood sample. And then at varying times, people were then diagnosed with the cancer. So those are the samples that we were pulling. And we have also, of course, more information from our participants as well. We have their stage of diagnosis, the grades of those cancers, and you can see actually for breast and prostate, because we do have screening mammography, for example, for breast, we do capture breast cancers at around 0 or 1. So the majority of the participants were captured early, but for something like pancreatic cancer, it's a fast, rapidly evolving disease, and many participants are diagnosed fairly late, stage 3 or stage 4. So obviously, the need for detecting and capturing these types of cancers, particularly these rapidly evolving cancers, using other alternative approaches is paramount. So we've been using plasma samples, and we've been looking for methylation signatures from cell-free DNA. And the way we do that is we do basic things at the very beginning where we sequence whole genome methylation sequencing from plasma. And what we can do pretty easily, and this is really that principal component on the right, the TSNE plot, is saying that we can separate out the different cancer types pretty well. And generally, when we compare with a population cohort like the OHS, we can match our cases and our controls pretty easily because we have tons of controls. So we try to match for age, obviously for sex, and for other risk factors as well, type 2 diabetes, BMI, smoking, alcohol, and so on. And what you're seeing here on a very simple principal component is that we separate out nicely for breast, prostate, and pancreatic cases from controls in our first pull of those samples. So we went back and we did a second pull, and that's generally what you're seeing here. This is data from a fairly substantial number. These are all the incident breast cases and all the and I'm only going to show breast for now. These are all the incident cases, and what I'm also showing you now is not just in black, which is when we collected the blood sample, and in red is when somebody was diagnosed with that cancer, but in yellow is information about when they last went in for mammography as well. So we have a way to evaluate whether there was a signature in plasma that captures that cancer, but that may not have been detected with mammography. Or at least what was the time lapse in between when mammography may or may not have captured that signature and when we see a signature of the cancer in the blood. And again, another breast principal component analysis shows that we're doing, again, really well using differential methylation, separating out breast. These are different ways that we've been looking at the data, taking, say, the top 150 hyper and hypomethylated regions in the sample, 300. In general, it's separating cases and controls pretty simply or easily. Kind of a fun thing that we're able to do also is that we're able to separate different cancer subtypes. Luminal A, luminal B seems to stratify pretty well with differential methylation. And then we went into doing a little bit more rigorous analysis, trying to develop a tool which gives us a risk assessment using machine learning approaches. So we do these tenfold cross-validations to get a sense of what the area under the curve is for these tools as well. And, oh, sorry, there we go. Generally, these are the numbers here. So we got around 93% accuracy here with OHS pre-diagnosis. And if we stratify our risk scores, we can see these survival plots also do a pretty good job as well of separating risk for our participants. We can also see that, and that's the picture on the bottom right, and the modeling is more challenging actually because it's not just a simple case control, because you have to include in your models that there's varying times of sampling, both for your cases and controls. And I'm not going to get into the math today. We have a separate paper on that, but we include that type of information when we're looking at our modeling. And that's why we have on the bottom picture this what's called the time-dependent cross-validation area under the curve analysis. We see there that regardless, we do varyingly with respect to different cancer subtypes. HER2 negative versus HER2 positive or HR positive vary with respect to accuracy as well. We also do extremely well when the cancer is more advanced, of course. That's because there's much more, if you like, material being shed by the cancer in the plasma. And we're also doing pretty well with, I didn't talk about this because we don't have enough time to talk about it, but this is data for prostate and pancreatic cancers as well. The fun thing about all this is with a population cohort like OHS or inside of CanPath is we capture all kinds of information about what people are exposed to as well. So we have interesting information, say, about how much people drink or smoked or other things, right? And what we can see here is our clear signatures of those environmental exposures, for lack of a better term, in these types of plasma liquid biopsy types of approaches. And we're just exploring that now to see if we can see very specifically whether there's an alcohol, say, induced risk associated with breast cancer as well. So just to summarize, large population cohorts enable us to be able to capture incident cases, and you need those large population courses to be able to do something even with a program that's been going on for 15 years because it takes time. And so arguably, this is a message for funders that you need to be supporting these types of activities for long periods of time because the real value in these cohorts is to be able to, I think, to detect these types of events and assess what are the real risks, what are the factors that are contributing to these diseases. And as I've hopefully been able to show, convince you of is that these cohorts and these types of tools can also see signatures of these diseases at varying times. One of the things that we think we can do with this data, for example, is see the signature of a breast cancer up to about 7 years before somebody was diagnosed with a cancer. At that point, the signal seems to fall off. So, which is somewhat reassuring. We'd be a bit concerned if we could see this over 15 to 20, 25 years, but maybe that's also speaks to the biology. Last thing I'm going to talk about, I'm not going to spend too much time talking about this today, of course, because of time, is, of course, population cohorts capture a lot of blood. And with these population cohorts, we have the ability then to look at not just, say, plasma, to look at solid tissue cancers, but also put the risks associated with, say, blood malignancies as well. And so, of course, we've been looking at age-related clonal hematopoiesis and seeing what kinds of features and signatures of age-related clonal hematopoiesis might be accruing in the CAN-path population cohort. Of course, the drivers of some clonal hematopoiesis might be, say, point mutations or larger chromosomal alterations. And so one of my students, former students, Kimberly Skeed, who's now at Regeneron, has been looking at these large clonal, what we call mosaic alterations, chromosomal alterations, which come in the forms of losses, gains, or CNLOHs, and see if they occur at varying degrees or preferential regions in the genomes. And we've also been doing this with other population cohorts as well. So the data that I'm showing you here is just the Canadian data, of course, and we can identify what we think are hotspots of these chromosomal alterations throughout the genome. This is just a quick snapshot of, say, chromosome 2, which actually seems to overlap with a known driver, these large chromosomal alterations, a known driver of clonal hematopoiesis known as DNMT3A. The interesting thing about some of these hotspots, or the locations of these hotspots, when we look within an individual, the allele frequencies, or the frequencies of cells carrying these mutations, tends to be higher for those cells compared to the mutations occurring in the other places in the genome, which of course then implicates then that these things might be real drivers and subject to positive selection as well. There are also this is actually an observation that's fairly well known, is that the number of chromosomal alterations that you carry is a really good risk indicator for cancers as well in blood. And the last thing I'm going to highlight is that if done properly and blood stored properly, it allows you to do things like single cell analyses as well. And so we have a study that's looking at if we partition our participants into varying groups based on health, we can actually assess at the single cell level where point mutations may be accruing and how that might be discriminating different health profiles in the population cohort. That's all I'm going to be presenting today. I need to, of course, acknowledge our funders. We have many funders from both at the national and provincial levels, and we're very appreciative of the support that they've been giving to CAN-path and to all of our partners. And I'm fortunate to be working with a really distinguished and actually fun group of scientists who are all great scientists in their own right, and of course have been very supportive in terms of developing the CAN-path cohort. So just end with the fact that CAN-path is now in its 15th year. We are available to the community. So if you're interested in the kinds of things that that I presented today, look up CAN-path and you'll find our website and our portal. And of course, I want to thank the students in my lab who've been developing those technologies that I was talking about earlier in the context of liquid biopsy, and clonal hematopoiesis. Thank you very much.
Okay, thank you very much, Dr. Awadalla, for a very interesting talk and finishing on time. So it's my honor to introduce the next speaker, Dr. Weang Ho. Dr. Ho is an associate professor at the School of Mathematical Sciences, the University of Nottingham, Malaysia, and a visiting scientist at Cancer Research Malaysia. Her research focuses on identifying the genetic and lifestyle determinants of non-communicable diseases. Today, she's going to talk about genetic risk assessment in cancer towards personalized risk management in Asian populations. Please welcome Dr. Ho to the podium.
Right, good afternoon. Thank you for having me. It's a great pleasure to be here to share with you on our work on breast cancer research. So why breast cancer? I think Joanne and Patrick actually set a really good scene. Similar to Singapore, in Malaysia, most of the breast cancer cases are actually diagnosed at late stage, so that contributes to high mortality. And the main contributors to that is because very little women actually come forward for breast cancer mammography screening in Malaysia. So about 25% uptake. So there's an urgent need to be able to do something, do better for the breast cancer control. So the main questions that we're asking is, how can we identify these women before the disease occurs? Whether giving them the personalized risk is going to help them to come forward for mammogram screening or not. And what's the role of genetic in this? So you have also, sorry, it's a wrong deck of slide. It's the wrong deck of slide though. Yeah. Well, I can continue to talk. So, yeah, I can continue to talk. It's okay. So you have heard this morning, like genetic is a very strong component of breast cancer, and you have also heard, how underrepresented is Asian population. So in breast cancer, only about 20% of the existing breast cancer genetic study are actually Asian. And what we are talking here is we're actually considering Asian as one population, but Asian is actually a very diverse population. So I have a very nice plot that I can show you shortly that how diverse is Asian population. So there are three key questions that we really want to ask, or I want to share with you today. So number one is polygenic risk score has been developed for the European population. Can we use it for the Asian population? The second question is, we know that existing clinical management criteria for BRCA1 and BRCA2 mutation has primarily been developed for the European population. Is our risk, right, Asian BRCA carriers similar to that of the European population? And finally, combining the two, can we use PRS to further refine the risk of Asian BRCA carriers? I think here's where I really need my slide. Here we go. This one? Yeah, yes. So this is a plot similar to what Patrick had shown earlier. So we generated these principal component plots using 10,000, actually 20,000 Asian samples. So you see how diverse is the Asian population. But I think one thing that I want to point out, also echo what Patrick said this morning, is it's actually quite, Malaysia and Singapore are quite unique because we have three of the largest ethnic group living under the same roof. So basically anything that we do here can somewhat form a basis to inform us about how a model that has been developed can be generalized to other Asian population. So the three key questions that I'm going to discuss today, I talked to you about it already. If we look at polygenic risk score. So what do we have in terms of the Asian breast cancer genetic data? So thanks to the long-term partnership between Malaysia and Singapore, we are now the largest breast cancer genetic study in Southeast Asia. We actually have more. So this data, this publication was published about 2 years ago, so at that time we had about 8,000 cases and 8,000 controls. Of course, that's small. We actually also collaborate with multiple international consortium so that we can have access to the data of these consortium who are Asian ancestry. We also work with multiple prospective cohort, Singapore Chinese Health Study, China Kadoorie Biobank, and Korean Cancer Prevention Study. So the number that you are seeing here is the largest that we have, but which is about just 20% of the size of the European population. So is this big enough? Is our analysis powered? Probably not for all analysis, but do we continue to wait? The answer is no, right? So we're going to do what we could from the data that we have. So the first question that we ask is, what is the utility of the European-based PRS in Asian population? I think if we just focus on the blue highlighted number, what's being reported in the European study is the odds of cancer is 1.61. The odds ratio, and then we applied the same thing in the Asian population, exactly the same set of genetic variants with exactly the same weight, and we found that the good news that it is predictive. So you see 1.5, which is above 1, means that it's predictive of breast cancer risk in the Asian population, but mindful that the accuracy is actually slightly lower in the Asian population. Then we went on to using the data set that I showed you earlier to try to further improve the European-based PRS. So we are basically asking the questions of, with the same numbers of SNPs, can we modify it so that we can come up with something that's better or more accurate for Asian population? So the answer is yes. So if you look at the second row, you're seeing the performance actually go from 1.5 to 1.55. If we use more fancy methods to develop the PRS for Asian population, so the genome-wide PRS actually developed using both Asian and European data. It consists of 1 million SNPs. You can see how the odds ratio per XT actually go all the way up to 1.62. And the predictive accuracy, AUC, 64% is actually similar to that reported in the European study, but 1 million SNPs. So why does that matter? I get this question a lot. You're talking about going from 1.5 to 1.55 to 1.62. What exactly does that mean? So if you look at this plot, it basically means that if I now offer enhanced surveillance to top 30% of the population with the highest risk as determined by the PRS, and then the proportion of cases that you can capture is actually on the y-axis. So you can see that if we use the existing European-based PRS, you'll capture about 45%. If you use the improved version, it goes up to 47%, and it goes up further to 49%. It sounds like a very small increment here, but if you think about applying this to the whole population, it's actually a significant number. So what does that mean is if you use the polygenic risk score and you stratify people according to their score, those who are in the top 1% of the BRS distribution, which is a bell-shaped curve, has the highest risk of developing breast cancer compared to those in the lowest category or the lowest tail of the PRS distribution. So what it means here is for a lot of the developed country, Asian developed country, who can afford to offer mammogram screening to all women, we may want to consider offer more regular screening or ask women to come at younger age for those that are at the top 1%, while those that are at the bottom of the PRS distribution, you may reduce the frequency of screening. One key point that I've been talking about a lot in every single talks, and which I think is incredibly important information, is so up to now, we know that the European-based PRS work for the Asian population, so important message for the ethnic minority in the West, right? But the key is it works doesn't mean that you can use the European distribution to do the mapping. So population-specific calibration is very important here. So that basically means that if I now want to use the same set of PRS in Vietnamese women, if I do not have the Vietnamese population to do that mapping, I'm likely to either overestimate or underestimate the risk of that particular population. So you can't just use it as it is. So if I move on to the second part, which is about BRCA1 and BRCA2 carriers. So actually, if you look at a lot of the genetic testing company, when I look through their brochure, they are still saying that BRCA1 and BRCA2 carriers, your risk is up to 70%, your risk is up to 80%. A lot of these estimates are actually based on the European studies. So what do we know about the Asian study? Prior to our publication early this year, so there are only 4 studies out there in Asia that look at BRCA1 and BRCA2 mutation carriers, so look at quantifying the risk. So what you can see here is the numbers are small, sample size is small, and there's a very large variability. So while the Korean study showed that if you're a BRCA1 carrier compared to a non-carriers, your relative risk is 18 times, but a China study showed that the same comparison is only 3.8. So the variation is very, very large. And most importantly, all these 4 studies assume that your relative risk actually doesn't change over time. So i.e., as long as I am a BRCA carrier, no matter I'm at 40, 50, 60, 70, or 80, my risk will be the same. The relative risk will be the same across all the age group. And what is the downside of that assumption? It means that we are likely to either over or underestimate the cumulative risk. So that's why we collaborate again, Malaysia and Singapore, with Joanne and Jingmei and Michael. So we managed to curate 572 BRCA1 and BRCA2 families, and the publication just came out early this year. So what do we find? So first of all, I think all I want to look at is if you look at the point estimate, this part really showing you that previous study that assume a constant relative risk across ages is actually inaccurate, because we can see from this data set that the risk does change according to your age. We also look at ovarian cancer risk just very quickly. Again, for ovarian cancer, the relative risk actually does increase over time. So Joanne has briefly showed this plot. So what I want to show you for this is for breast cancer risk of Asian carriers in Malaysia. So I calculated this one using the Malaysian population cancer incidence. And what we are seeing here is for the 3 ethnic groups, so you have Chinese, Indian, and Malay, the cumulative risk of breast cancer, although they are all BRCA1 carriers, are actually different, right? So the risks differ across to ethnic group. And same go to BRCA2, and you can see all the numbers that we are reporting here is actually lower than those that's reported in the European population. And the reason for that is because our underlying population cancer incidence is actually lower. So if I recreate this plot for the Singaporean population, you're going to see that all these numbers are going to shoot up. So same go with the ovarian cancer risk. So we don't have the data to generate the ethnic-specific ovarian cancer risk. But you can see that the cumulative risk in the blue, 31% and 12%, is actually not that far off from the European estimates. And the reason for that is really, I think the ovarian cancer incidence is actually quite consistent across different populations. When we fit the model and run the analysis, we actually takes into account the birth cohort difference in our sample. But even we account for that, when we do the prediction, we can see that the risks are still different across different birth cohort. I think this really just echo what Joanne has said. This suggests the contribution of lifestyle reproductive factors to the cancer risk. This is an interesting plot. Again, Joanne showed it briefly, but what I want to bring your attention is if you look at the 3 blue lines, the top is the US population. Cumulative risk for BRCA1 carrier is 71%. And then the second blue line is for Singaporean Chinese, 65%. And the bottom blue line is for Malaysian Chinese, 56%. So the orange color is for UK, Singaporean Indian, and Malaysian Indian. So what this plot shows us is not just your ethnicity matter, where you live also matter. These all go back to because of the difference in the underlying population cancer incidence. So finally, can we use PRS to further refine the risk of BRCA carriers? I think one of the motivations here in Asian data, especially in Asian developing countries where we know that the corresponding cumulative risk for BRCA carriers is actually lower, if we can further stratify the risk based on PRS, we can identify those that are high risk, encourage them to come forward for surveillance. And for those that are low risk, women can make more informed decisions, right? Especially in terms of when do they want to do the surgical prevention. So what do we do? So this paper hasn't been published. The first 2 rows are the PRSs that I showed you right at the beginning. So these are developed for the Asian general population. So you have PRS with 333 SNPs. You also have PRS using that 1 million SNPs. And the bottom 3 rows are 3 PRSs developed for the European population. All 5 of these PRS has been validated in the Asian general population. So now the question is, can we use these PRS developed using the general population to predict risk in BRCA carriers of Asian ancestry? We work with SIMBA consortium, so in total we have 604 BRCA1 carriers and 785 BRCA2 carriers. Again, very small, but we do what we could. So what do we find? If you look at the red row, okay? So PRS 333 is the one that I showed you how we can improve the European-based PRS, and it has improved accuracy in the Asian general population. So if you now focus on the p-value column, to make it straightforward, it's actually not significant. So it means that these PRS that work for the Asian general population is actually not predictive of risk of the Asian BRCA carriers. If you look at the second red row, that is the European-based PRS with the 313 SNPs. So with these PRS now actually being evaluated in a lot of the ongoing clinical trial, what does this mean here? The p-value is again not significant. So European-based PRS is predictive of risk in the Asian general population, but not in the Asian BRCA carriers. And the only things that turn out to be significant in this analysis is the blue row, where if you use 1 million SNPs, then it is predictive of the risk in Asian BRCA carriers. And what does that mean? So this is again generated using the Malaysian population cancer incident, breast cancer. And we see that on average, right, the middle line show the difference in terms of the cumulative risk for Malay, Chinese, and Indian in Malaysia, which I showed you earlier. But if you apply this genome-wide PRS to this population, you can see how we can further refine the risk of BRCA1 carriers in Malaysia. Same go with BRCA2. Again, you can actually recreate that for other populations. So what are the takeaways here is, can we use, is PRS useful for stratifying breast cancer risk in Asian population? So the answer is yes. We have a minor modification can actually give us a better PRS. It means that if you implement it, you can capture more cases in the population. But if the panel has been developed, right? For example, in the West, when they want to use the European-based PRS to the Asian population, can they use it? The answer is yes, but the key here is the population-specific calibration, or else we are still not giving people the precise estimate that they deserve. BRCA1 and BRCA2, with the publication that we have early this year, like Joanne said, it's the first time that we quantified the risk for Malay and Indian population, and we refined the risk for the Chinese population. We hope that eventually we're going to see the number change in a lot of these brochures, the genetic counseling. We can provide more accurate risk to the Asian BRCA carriers now. So the key message here is really, because of the difference in the underlying population risk, our risk, even though we are BRCA carriers, may not be as high, right, as the European. Of course, it depends on where you are. And finally, there's potential of PRS to further stratify the risk of BRCA carriers. But I think we need more data there to be able to develop something. The key message here is really the European PRS is actually not predictive. So we need to be a little bit careful, especially when study in the West launching PRS for BRCA carriers. What about other risk-associated genes? So we haven't done a lot in this area, mainly because of the sample size. So again, the Singapore and Malaysia study, we both contributed to this study called Bridges, where they sequenced 34 breast cancer risk genes, or the candidate breast cancer risk gene. And they found that apart from BRCA1 and BRCA2, there are actually other genes that are associated with breast cancer risk. They are rare in the population, maybe not as rare as BRCA1, 2, and they are associated with moderate risk with breast cancer. So this is one of the studies that I love to show. So this study in the European showing that if you are a CHEK2 carrier, then your risk is elevated, right? Not as high as BRCA1, 2, but a lot higher than the general population. So when they apply PRS to CHEK2 carriers, what you can see is those in the bottom, so the 8%, they actually push the risk all the way back to the population average breast cancer risk. So imagine we have something like this for the Asian population. What would that mean? Because Asian population already start with lower risk for some of the countries. If you can apply PRS to CHEK2 carriers, for example, those CHEK2 carriers in the lower PRS category probably is going to have a risk that's lower than the population average. But how do we get there? Can't get there without collaboration. So if you have this data and if you appear on PubMed, you're probably going to start receiving emails from us. So we're really calling for collaboration here so that we can replicate what we have done for BRCA1 and BRCA2 carriers for Asian to do it for other risk-associated genes. Just final slide here. So acknowledgement, this wouldn't have been possible with the contribution from all the studies and all our collaborators. Thank you.
Thank you all, and thanks to the speakers. So I now invite all the speakers to the stage so that we can. Okay. Let me see if I can. I've learned how to use this. Okay. So based on the votes, and thank you all for very nice presentations, I'll start with this question. So we have, oh, sorry. Yeah. So we have a question that says, nice talks. This is a general question for Joanne. A lot of my non-Singaporean friends complain of symptoms related to IBS in Singapore. Can untreated IBS lead to colorectal cancer? What environmental factors lead to colorectal cancer? Oh, that's a very big question, but yeah, please.
Well, firstly, I'm not a gastroenterologist. We'll be speaking a little bit out of turn here. But I would say in general, we don't know enough about the etiology. And then within IBS, I'm trying to understand whether this is irritable bowel syndrome or is it inflammatory bowel syndrome? Because IBS, inflammatory bowel syndrome, would certainly, there's a risk of CRC, and there are some genetic correlations there. Irritable bowel syndrome itself, I'm not aware, so I guess I need some clarification about which IBS this is.
I guess when people say IBS, they mean irritable bowel syndrome.
Okay, so for that, I think we'll probably need a lot more greater data, and it also requires other kinds of data, including the microbiome, the gut microbiome, GI microbiome, in addition to that. Yeah. But it is a big problem, not to dismiss the issue.
Any other? So yeah, just I think that probably the reason, I mean, IBS per se probably is a very vague, clinical diagnosis. So probably what happens is that there are many symptoms that are shared with early symptoms for colorectal cancer. So my guess is that a lot of the reason is probably somewhere there. So the next question is, there are existing PRS development methods for accounting for population. Are there existing PRS development methods for accounting for population differences? Would these algorithms be helpful in the context of improving risk prediction in context of cancer? I think this is mainly for Dr. Ho. Yeah.
I think there are two elements here. So the first element, if I understand the question, is there are currently trans-ancestry methods where you can incorporate both the European data and the Asian data or other ethnic minority data. And it accounts for the population differences like it's suggested here. And does this algorithm help in terms of improving the risk prediction? The answer is yes. That's why you are seeing the PRS with 1 million SNPs, which is developed using both European and Asian data, and it improved the predictive accuracy. I think the second element is more on, so these are two separate things. The second element is about the distribution that I mentioned earlier, where I say population-specific calibration is important. So even if you develop this data using the multi-ancestry training data, European, Asian, or all the Asian cohort, you throw it in and generate a PRS, you will still see a difference in terms of the PRS distribution. Hence, you still need to calibrate when you want to use the PRS for a specific population.
Can I just add that to this particular question, the sample size is absolutely important. And I think we're all involved in the NIH-funded study, the Confluence study, was going to dramatically increase the number of samples. So a lot of, I think, what was presented will get, sort of reassessed once that data is ready. So I kind of think we're almost there. So we kind of should just sit tight a little bit with this. The question will be answered.
Thank you. So the next question is for Philip, because we didn't ask Philip any questions. So what do you think of the multi-cancer liquid biopsies, for example, GRAIL?
Oh, wow. I think what's well, maybe this isn't answering this quite as directly as maybe liked, but I think what's interesting about, and there's not a lot of transparency on some of what these tools are capturing, but there's overlap, I think, in a lot of these signatures. When there's a cancer present, it may not actually be that the signature is coming directly from the tissue that's impacted. If there's an some sort of immune process that might be impacted by the development of that cancer, anywhere there's damage in the body, you'll start to see a signature. So it's one of the reasons why I try to make an argument that methylation type signatures give you some kind of indication about the tissue specificity as well.
Thank you.
Maybe just add something here as well. Sorry because we get asked these questions all the time, right? In our cancer genetics clinics and all that. One of the things that happened last year, we attended an FDA session. It's really important that anyone's doing MCEDs that the study is designed specifically for what it's intended to do. And FDA harps on it. The fact that if you want to find a stage 1 or early stage, the study should be designed for that. And so if there's anyone in the audience who's trying to do MCED studies, it should be appropriately designed that way, because otherwise we're confusing the ground where we include different stages of cancer in the study design and etc. And that's just a point for anyone who's thinking of doing MCEDs.
Thank you. The next question is, how far are we from implementing the Asian breast cancer PRS to general public in Singapore and Malaysia? Any means for general public to access the Asian breast cancer PRS today? I think
Malaysia first. Well, I think the good news is Patrick talked about BRIEF, and then BRIEF actually adopt the European-based PRS. So in the Malaysia context, it's slightly different. So in Malaysia, we do not have a population-based screening. We only have opportunistic screening, and also need to be mindful about the cost. Who is going to pay for the genetic testing? So at the moment, the team is actually running some health economic analysis, basically trying to answer the question on where can we implement risk-stratified screening, when. So which are the target population? Should we offer that to the 25% of women who already turn up for screening, encourage them to come back for screening? If the health economic analysis say that you should target the 75% that never turn up, how are we going to identify them? So I'm not giving answer here, raising a lot more questions. So for Malaysia, I think we need a lot more evidence to support how we can implement PRS in the population.
So I actually agree with Yuki very much that the evidence is still evolving, is still being developed. And so from that context, I think it remains very much on the research front for us to understand not just the cost effectiveness, but also the composition of the PRS, right? Because as we say, with the confluence data coming out, there'll be more information there. And the other thing I want to highlight is like 80 to 90% of people who have HBOC or Lynch syndrome, where they're highly penetrant, they are not able to access sort of clinical genetic testing freely at this point in time. It's still kind of, they're not reimbursed for it, etc. So I kind of feel that at the same time, while that's being developed in parallel, while we understand PRS will be very useful eventually, we also need to address those who are high penetrant, who are actually not getting care at the moment.
Just one more comment on that. PRS is not like monogenic gene, where once you get it, the risk is incredibly high. I think there are ongoing research study in terms of how do we communicate the risk to women. So for those who are at high PRS, that's not as high as those that are BRCA carriers. What do we tell them? How do we tell them, and what can we recommend to them? So there are ongoing clinical trial to study this.
So this is for Joanne, SG10K. How do you make sure that those recruited participants labeled as healthy are truly healthy? Do they get through a battery of tests to rule out different diseases of interest?
So SG10K is actually a composition of different cohorts, but SG100K, which is what we're moving towards, is actually a sort of population cohort as opposed to a healthy cohort. So we just get people from the community who are recruited from the community. So it's not entirely healthy. There'll be people with diabetes, et cetera, et cetera. SG10K, which was the data that I presented, did include populations where they were asked whether they had diseases and all that, and that's a more healthy cohort. SG100K is more a community cohort, and there would be things like metabolic disorders and all recruited in that. And they do go through a battery of tests in SG100K. It's actually a 4 to 5 hour journey, which has now shortened to about 3 hours because the team has gotten very efficient. And they go through a whole series of tests. They go through a treadmill, ultrasound carotids. I think you heard Patrick mention a study that uses that, bone mineral density testing, lung function tests. It's a whole series of battery of tests, actually.
Thank you very much. I have a tough question for Philip. What is the ethnic background of Canada? Natives, immigrants.
Right, so the Statistics Canada numbers I have on the top of my head are 70% of our population as of a couple of years ago still self-identify as largely white, and 30% other. Now, CanPath generally reflects that in terms of our recruitment, and I can safely say that about 10,000 of our participants in CanPath self-identify as Indigenous as well.
Thank you very much. Yeah, that was tough. So the next question, again for CanPath, is how do you ensure that you're able to follow up on your participants? What are the types of data that you collect to ensure that you're able to recontact them, address, phone numbers, etc.?
Right, so that all comes down to first consent. We had a fairly broad consent, and perhaps we were a bit naive in how in that consent because we left it pretty open-ended, which allowed us to be able to link to various types of data assets anyway. So we could have been smarter about that, and then that might have limited us in the future. So we kind of unwittingly future-proofed ourselves to some extent. So that consent, of course, did allow us to recontact our participants. So we're in our around 4th or 5th round of reconsenting with regard to questionnaires, and that consent also is a fairly broad consent allowing to linkages to various administrative data assets, including things like Statistics Canada. Even though we do have a 10-payer system in each of our provinces, we also have our ability to not only link at the provincial level to clinical outcomes, but also to national data holdings for that type of information as well. And we just this year actually signed agreements that allows us to be able to host that national linked administrative data at CanPath in a trusted research environment. So it's a one-stop shop now, if you like to have access to that information. And yes, we do have addresses and phone numbers to support our recontact of activities as well.
Can I ask him a question?
Yeah, sure, please.
So for your TRE environment, did you have a lot of debate about a sort of in-house built or a buy from outside?
Consistent, it's constant, sorry, and you know, one of the things that keeps coming up is that there are many of these trusted research environments, and there are many trusted research environments supporting various activities, even just within Canada, and of course population cohorts around the world. So we went through a procurement exercise, and we did land with one provider, and so we're going to be in the AWS cloud with LifeBit, so which is, I believe, the same provider for Precise. In the meantime, that doesn't stop us from also hosting data in other environments at the same time. We want people to use the data, so if there's another activity where we can still administer that data and oversee that data in another cloud environment or cloud-like environment, we're still open to that as well. But yes, we still have conversations about what is the most secure environment and whether these are more secure than historical or, ancestral approaches.
That's a very sensitive, yeah, an important question. So the next one, because it has been repeated in other questions as well, is although genetic predisposition of breast cancer is higher in Indians and Malays, but is the disease penetrance still higher in the Chinese?
I think the data set that we both showed in our slides suggests that that may be the case. And I think it's largely lifestyle driven, yeah.
Where the underlying population incidence is actually higher in Chinese, at least in Malaysia, then followed by Indian and followed by Malay.
Thank you. Next question is for Philip. Thank you, Philip. Yeah, thank you, Philip. Do you see cell type-specific mutation patterns for the classical list of CH genes in your single-cell data? Do you have an estimate for accuracy of variant cells, such as using such data?
Yeah, so calling somatic mutation, we'll start with the latter one. So calling somatic mutations from single-cell RNA sequencing data, so that's the data we're using, is tricky business, particularly for blood. We made sure that, of course, we called germline whole genome sequencing at the same time, so that we had that as a reference. So we have, we were actually quite lucky in that project. We had both ATAC whole genome sequencing, traditional whole genome sequencing, coupled with the single-cell RNA sequencing to support our ability to call those mutations. But yeah, there are other factors that can come into play, like allele-specific expression can get confounded with confounded with somatic variant calling, or looking at those frequencies in different cell types as well. And yes, we do see cell type-specific mutations. Some of this is canonical, occurring some in the myeloid lineage versus lymphoid. The fun part about that study is that when dealing with a population cohort like CanPath, you can really stratify who you think is your super healthy population and aged compared to other individuals. And so that's, for me, that's become my favorite project, in fact.
Thank you very much. So the next question, there are many cancers with not many population differences. Besides, the heritability of cancer is often below 50%. Do we really necessarily bet on genotyping every cancer?
So I guess the question is asking about, to detect sort of inherited cancer syndromes, are we advocating genotyping every cancer, or are we going to go sort of cancer specific? So I think there are quite established guidelines. There's certainly cancers where the likelihood of a germline, Mendelian disorder is very high. So for example, pheochromocytoma, paragangliomas, that can be 40%, medullary thyroid cancers, that's 20%. So there are already guidelines to do a histology approach. But these days, with the cost of testing coming down the way it is, there are many guidelines advocating that we take a universal approach. I think in the US especially, breast cancer, ovarian cancer, pancreatic cancer, colorectal cancer almost have gone down almost the universal testing approach. I think, I mean, as a scientist, I would love that to happen. But I think from a policy standpoint, then we would just have to do the economic analysis. I think we'll learn a lot by doing that, for sure. And I think we will get to the point where we can define which ones need and which ones don't. Yeah, I would love to sort of be able to answer that for Asia. We haven't quite answered that yet.
And probably not just cancer.
Yeah.
So when we think about developing countries where resources is limited, if you now say that let's generate a PRS for just breast cancer, it's hard to justify that it will be cost effective, honestly. Yeah. If you can generate multiple diseases, we're going to bring the cost further down.
Yep, that's true. The next question, which also my question, is that regarding the Asian PRS scores, does the lowered Asian risk scores impact the way you counsel breast cancer patients for genetic testing and vice versa?
This is an interesting question. If I understand it correctly, it's asking whether those in lower Asian PRS score will be recommended also for the BRCA genetic testing.
I think that's
the question.
Yeah.
Joanne probably can answer this better, but my gut said that the two things shall not be lumped together. BRCA genetic testing has the standard procedure or guideline, clinical guideline, which actually go down there first. So once you identified that person, whether it's a BRCA carrier or not, that's where you apply PRS and try to further refine their risk. It's not the other way around.
Yeah, I think this is a dangerous situation that can happen, right? So for example, the scenario would be that this is a sort of strong family history of breast cancer. They go and they buy one of the off-the-shelf any off-the-shelf DTC tests, and they get a European PRS that's not really been established for the Asian context, and they get a very low PRS score, and then they get told no risk, and they go away thinking that that's no risk. So I think this is certainly a situation that we want to avoid. And then the other thing that I think doesn't get enough attention is the work from Paul James, right, where it talks about even if you have a pathogenic variant, etc., the range of your risk, ATM, CHEK2, and the rest of it, can change so much by other modifier genes that you can actually be below, what is normal. So there's still stuff. So my simple view of life is there are certain things like BRCA1, BRCA2, and Lynch, and some of the other hereditary. We need, if we can do better for that group of patients globally, I think the impact would have been huge. So that's kind of my simple viewpoint.
Thank you very much. There are some still very interesting questions, but we are running out of time. I would like to ask the speakers if they have any last thoughts or anything that they want to finish.
Oh, right, okay. So, well, I'll just kind of address one of the questions here. So I think, the polygenic risk scores are obviously important. We need to start somewhere when we're thinking about risk stratification and being more aggressive. And yet, we also need to be thinking about, yes, 90%, 95%, even in the context of breast cancer, won't have a heritable mutation. So there's a question on the screen around on CanPath. So many of the participants where we saw a signature, for example, only about 5% actually had a heritable mutation. So in a sense, there's got to be an approach where both PRS coupled with these new technologies and also some more advancement on not just detecting a cancer, but also being able to say to somebody, you have zero or close to zero risk, is just as important. Most of these technologies are kind of veering away from that type of science. And that's the hard one, because you need to be able to, that's easier to sell a participant or a patient that they have low risk or zero risk. 10% is tough.
I just want to say that I feel quite grateful that the precision medicine effort in Singapore is taking account both the two houses, right? The science, but also the clinical side of things. And I think that's for me a very important part, because a lot of research has a lot of the data, but we don't have, we don't build in the resources for the downstream clinical implementation. And that's where everyone's waiting for another payer, whether it's a third-party payer, which is insurance, or whether it's the ministry or what, everyone's waiting for someone else. But I think we do need to fund that part so that we can then see what is the right model to then propose to payers. I think the payers are not prepared to do the research for us. And so this is something that I think we're a bit fortunate here, that we have both parts of the house, and not every program, I think, takes that into account.
I think just one message that I kept repeating in every single conferences. We are genetically different from the European population. Good news is we show that now a lot of the data generated through the European population is actually applicable to the Asian population, at least for breast cancer. That's a good news. But the problem there is people will just take whatever is reported in the European population. So that basically means that you're either overestimating or underestimating the risk of Asian population. So we need to move away from that. More attention needs to be paid to this issue.
Okay, that's a very, very important point. So I have a few important reminders here in front of me, and I can see 6 big zeros here in red, so that means the time's up. So this is a gentle reminder to speakers and moderators. There is a welcome dinner this evening. There will be a bus that will take you to the dinner venue. Be at level 1 by 5:50. The bus will leave at 6. And please note that the dinner is invite only. Don't bring your friendly neighbors, etc. So, and for all other conference attendees, our sponsors, PacBio and also LifeBit, warmly invite you to their evening networking events immediately following day 2 tomorrow's program. Please join them for a special evening to connect with industry leaders, experts, and professionals. And thank you very much. Thank you, the speakers and everybody here. And yeah.